Well, thanks very much to Daisy, and thanks to everybody for being here. I've been told that I shouldn't move around very much because I'm in the spotlight, which I'll have to work on that because I tend to sort of walk and talk, so I'll have to remain in light. So as Daisy indicated, I am a philosopher. That should not intimidate you. We will be doing some philosophy this evening, but it will be, I think, philosophy with a light touch. We'll be thinking about some central issues in the philosophy of medicine, and more broadly, I guess, philosophical issues about human well-being, what the difference is between being ill and being well. So the subject of the talk is, of course, grief. So let's begin. Oh, there we go. Went one further there, but there we go. So let's begin with some numbers. These are, I take it, distressing numbers. As of Monday, the worldwide death toll from COVID amounts to just over 6 million people. Those who study grief and bereavement tell us that for each of those individuals who die, there are 9 individuals who undergo significant grief episodes. So, though I'm not a mathematician, that seems to work out to about 57 million additional grief episodes in the world due to COVID. And my guess would be that, as with many things related to the pandemic, that's probably a pretty significant underestimate. That is both an underestimate probably in terms of the number of deaths, but also in terms of the number of people affected by those deaths in the way of grief and bereavement. So we are confronting, I think, a large-scale global grief event. I think probably for most of us who are alive today, this is unprecedented. The increase in deaths from COVID above sort of the natural or existing rate of death is not something that we've seen, say, since World War II, or perhaps the last great pandemic in the world, which was the Spanish influenza epidemic that occurred between 1918 and 1920. So we are certainly looking, I think, at what we can safely call a large-scale global grief event. Now, one interesting feature of COVID and grief that I won't be particularly touching upon, not because it's not important, but because it's simply not my topic this evening, are the various disruptions that COVID brought to grief and bereavement. So for most parts of the world, COVID represented an anomalous way of dying in the sense that in most of the more prosperous parts of the world, people don't tend to die primarily from infectious illness. They tend to die from cancer and heart disease and other kinds of chronic illnesses. And so the experience of dealing with individuals who are dying or dead due to infectious disease was perhaps novel in certain respects. And this caused, I think, a lot of disruption to grief and bereavement itself. So just looking at what you see here up on the slides, you see there in the upper left a woman who is separated by a plastic partition from a loved one who is stricken with COVID and would later die. You see in the lower left there a socially distanced funeral. This was the norm for much of the pandemic in many parts of the world. Or for those who were unable to attend because of travel restrictions, they, of course, would often participate in funerals via a live stream, as you see in the upper right. And then there were some, I think, especially distressing phenomena related to the ways in which the fact that the COVID corpse, if you will, is infectious, is biohazardous, necessitated some alterations in the ways in which human corpses were interred. So in the lower right there, you see a photograph of one of the sort of mass cremation sites in India, which had to be put in place because there were simply not enough opportunities to cremate people in the ways that families would typically desire according to Indian Hindu culture. And so you had these sites that were in effect kind of mass funeral pyre locations. So there are a great many disruptions to grieving due to COVID. And that, I think, is an important and worthwhile issue to think about. But what I want to focus on this evening is actually somewhere else. I want to focus in particular on some language that you've started to see some experts and some members of the media use to talk about this global grief event. You're starting to see members of the media use this phrase, grief pandemic. So these are headlines drawn from, respectively, the United States, here in the UK, and Australia, each of which are instances of medical experts and journalists describing what it is that we are looking at, this global grief event, as a global pandemic. And it's that pandemic language that I want to put under the philosophical microscope tonight. I want to invite us to think critically and carefully about whether we should embrace this particular language of a grief pandemic. To use language of a pandemic, of course, is to use medicalized language, right, to describe this phenomenon in ways that invite us to think of this global grief event as a medical event. And what I want to do is to give you all some reasons to chew on as to why I think we should resist this particular way of talking about the global grief event as a pandemic. So what I'll be doing is, in effect, this, or my primary goal will be to do this. I want to argue that this epidemiological turn, right, sort of thinking of the pandemic as itself as pandemic grief as itself a kind of epidemiological event in its own right, that we should resist this particular talk, and in particular we should resist conceptualizing this mass grief event as a pandemic. And my reasons for this will rest on the idea that this represents an unfortunate and misguided tendency to medicalize grief, right? A tendency to think of grief as itself a kind of medically problematic condition. So that's where the sort of heavy-duty philosophy will be this evening, to try to persuade you that we ought not medicalize grief, and as such, this language of a grief pandemic is language that we should not be particularly sympathetic toward. So roughly here's the plan. I want to begin by giving you a little bit of philosophical, but also, I suppose, historical and cultural background about the notion of medicalization, and a little bit of background about what some philosophers have said about the nature of disease. Then, I suppose, the heart of the talk will be in part two, when I give you some reasons as to why it is that grief shouldn't be medicalized. And at the very end, and somewhat briefly, admittedly, I'll be talking a little bit about the ways in which I think there's an unfortunate trend embodied in this talk of a grief pandemic, an unfortunate trend wherein we relocate large-scale social problems as matters of individual pathology. So let's just begin with this notion of medicalization. So those who study medicine from a social scientific perspective, sociological, anthropological, historical, often note that different conditions over time are medicalized or demedicalized. That is to say, different conditions are, at various points in history or in different cultures, treated as medically significant conditions, as illnesses or diseases. So to give you just a few examples of conditions that have been medicalized, alcoholism, right up until roughly the middle of the 20th century, was generally seen as some sort of moral failure on the part of the alcoholic, or if you tended toward a more elaborate, I suppose, religious worldview, as an indication of possession or some sort of deficiency of character, due to sort of your place in the religious order. But around about the middle of the 1950s, 1960s, a number of researchers and clinicians began to say, well, I think we now understand that alcoholism is the consequence of a number of factors, genetic makeup, exposure to alcohol at different ages and that sort of thing. And what we have here is an instance of medically significant addiction. So, it became quite commonplace, and I think it is now commonplace, right, to think that alcoholics are suffering from a disease. Obesity, right, is another example of this. I think in recent generations, we've begun to think that obesity is a bit like alcoholism in the sense that it's the byproduct of genetic factors, lifestyle factors, environmental factors. It's not necessarily an indicator that someone is of sort of bad character or has vices such as gluttony or lack of self-control or any such thing. It is understood and treated in many quarters as a disease. Menopause was a condition that up until the middle of the 20th century was similarly thought of as, well, just a kind of stage in women's lives, not something that medicine should be concerned with in particular. And then finally, infertility and sexual dysfunction, right, were, for most of human history, not really thought of as medically significant problems. They were misfortunes, perhaps, but not to be thought of as subject to medical treatment. Now that's just a tiny scratch on the surface, really, of the conditions that have become medicalized over time and place in history. The number of demedicalized conditions is not quite so many, but there are a few that we can take note of. One is homosexuality, right? So In the English-speaking parts of the world, homosexuality was, until the 1950s or 60s, included as a mental disorder, right, in diagnostic manuals and so on. And then we can also, I think, view childbirth, at least to some degree, as a phenomenon that has been demedicalized, at least for some women. Many women opt for birthing experiences, right, that are demedicalized in a large degree, without obstetricians necessarily present, without analgesics or other kinds of drugs used to treat pain. So those are some examples of conditions that have been demedicalized. But I think that any fair reading of history will tell us that the trend is and continues to be in the direction of medicalization, right? The number of conditions listed in medical diagnostic guides continues to grow. And every time these guides are revised, nearly always more conditions are added than are taken out, right? Now that, of course, raises the interesting sort of question, are we getting sicker? Right? I mean, on balance, are we in fact sicker than we were in the past? Or are we simply noticing only now that we were sicker than we thought we were all along? So that's the phenomenon of medicalization. Now, there are always going to be, and continue to be, disputed cases, right, of what are classified in some societies and some medical cultures as disease. So just to give you a sense of some recent controversies in this area, attention deficit hyperactivity disorder is included in most of the diagnostic manuals used throughout the world. It's thought of as kind of developmental disorder. But there are persons with some credibility, I think, who believe that attention deficit hyperactivity disorder is merely one indication or one point, right, along a kind of spectrum of human personality. That there are some people who have difficulty paying attention and keeping still and so forth. And this is not a medical problem, but simply a kind of variation, right, in the human species. Some of these critics in particular believe that attention deficit hyperactivity disorder amounts to kind of pathologizing the normal condition of, well, young boys, right, since overwhelmingly they are the ones who are diagnosed with this condition. Restless leg syndrome is another one that has been subject to much controversy. Some believe that, again, this is probably not an illness exactly, but again, a kind of variation in sort of people's neurology or the ways in which their nervous system functions. Premenstrual discomfort is one that continues to be debated in some circles. Are women who undergo this kind of discomfort actually ill, or is it simply a part of the experience of being a woman of childbearing age? And chronic fatigue disorder, baldness, all of these are examples of conditions that are still sort of open to dispute, right? That people don't exactly agree upon, right? There's not clear consensus as to whether or not these are diseases or illnesses or not. Now, Ivan Illich, whose book I have on the slide here, wrote this book in the 1970s called Limits to Medicine. And Illich didn't develop the term medicalization, but he was, I think, the one scholar who probably deserves the most credit for second-guessing, right, the trend toward medicalization. He described what was going on in his eyes in medicine as disease mongering, right, sort of finding more and more, right, illnesses over time. Many of which he thought were not really illnesses. They were simply variations, again, in the human species that may cause people difficulties of different kinds, but didn't deserve to be treated as illnesses. So as he would often say, he thinks that thought of medicalization as medicine's attempt to recast what is normal in human life as pathological. Now, the question at hand for us will turn out to be whether we should think of grief as a kind of illness or disease, or whether instances of grieving can be illnesses or diseases. But I don't intend to offer a thorough accounting this evening of medicalization, or which conditions should be medicalized or not. But I want to focus instead on a specific way that we should think, in my estimation, we should think about the question of medicalization and illness and disease, and then apply, right, that particular set of insights to the phenomenon of grief. Now, it's important, I think, to realize that the power of diagnosis and classification of illness is very, very central to medical practice, right? Without illness, without disease, what is medicine? Right? Well, not much, right? I mean, it's sort of hard even to know what medicine would do with itself, or why it would have the social significance or power or authority that it has in the absence of illness or disease. So I think many sociologists and philosophers of medicine have concluded that of the powers that we assign to medicine, the most powerful ones are the powers to classify some phenomenon as a disease, to say of some condition of a person that they are ill, and then, secondarily, to diagnose individuals as having that condition. Right? Without those two aspects of medical practice, there really isn't much to medicine. But that then raises a question that, while important to medicine, is not really a question within medicine. Right? And that's the question of, well, what is disease? Right? Can we understand what it is for a condition to count as, rightly, a disease or an illness? When we look at, again, attention deficit disorder, restless leg syndrome, and so forth, what criteria, right, should we deploy in thinking about whether or not these are in fact illnesses? Okay. Now, if we had, gobs and gobs of time, we could hash out different ways that philosophers and theorists of medicine have thought about the nature of disease. But I'm going to proceed in a somewhat more dogmatic way by offering forth what I think is the most plausible view about the nature of illness and disease, and then proceed to ask whether, or what that particular view about the nature of illness and disease implies about grief. So the model that I'm going to urge us to adopt is what is often called the hybrid model, okay, of medical disease. And what it says to us is this, that in order for some phenomenon to be a medical disease, it must first be a dysfunction of one or more bodily systems. There must be some respect in which one's body is not functioning as it ought. And then secondly, that this must be a condition that is harmful to those that have it. Okay. So as I said, I don't mean to hash out all of the philosophical issues raised by this particular model of the nature of disease, but just to sort of motivate it a little bit for you. There do seem to be conditions of individuals that are dysfunctional, but not obviously harmful. So, for example, occasionally, right, people will have hormonal conditions that lead them to be unusually tall. Right? Arguably, their hormonal systems are dysfunctioning. Right? They're not functioning in the way that they were intended. But it's not clear that being unusually tall is typically harmful to people exactly. Admittedly, right, it's going to be a little bit tougher to squeeze into an airplane seat. Maybe you'll stand out a little bit among your classmates when you're young. But it's not clear that being atypically tall is exactly a harm to you. Nor, I would say, being, roughly how tall I am, is being unusually short. Okay. Likewise, right, there are behaviors that are not dysfunctional, right, but perhaps are harmful to people. So it's been debated in psychiatric circles for some time whether we should think of compulsive sexual behaviors, right? Sort of, compulsively seeking sex, sex addiction, if you want to call it that, whether this really amounts to an illness, right? Well, it's not clear that one's body is dysfunctional, right, when you have a lot of sexual desire or you seek out a lot of sexual partners. But maybe it's harmful to you, right? People who report having this condition kind of wish that they didn't have it. They think that it's kind of an encumbrance on their lives. So what seems to be clear is that dysfunction and harm can come apart, right? There are conditions that are dysfunctional, but perhaps not harmful. There are conditions that are harmful to people, but not dysfunctional. But when you bring those two together, it seems credible to think that what we have in what we are in the presence of is a disease or an illness. And I think when you think about the conditions that we would all agree are pretty clearly diseases or illnesses, they will satisfy the two criteria of the hybrid model. They will all be harmful dysfunctions. When you think about diabetes, well, that's a dysfunction of your system for producing insulin, right? And it's clearly harmful to people. Gone untreated, diabetes is certainly quite uncomfortable and in some cases fatal. So too for most infectious illnesses, right? Those are clearly in many cases harmful to people, involve dysfunctions of bodily systems, attacks on tissues within the body. Cancer, heart disease, the other sort of major things that tend to be responsible for people's deaths nowadays, all of these seem to fit this category of harmful dysfunction. So it does seem to me that, again, some philosophical subtleties notwithstanding, that the hybrid model looks like a pretty promising way to think about illness or disease. Okay. Now the question at hand, going back to our initial observations about talking about this mass grief event as a pandemic, is whether we should think that grief, right, ever meets these conditions. You'll note that in the way in which I'm speaking here, we needn't think that grief necessarily or always meets the conditions for being a pathology or an illness. It could be the case that it only sometimes does. So what I think we're interested in is whether, in a kind of generic way, right, thinking about grief in its typical manifestations, we should think that a person who is undergoing grief is ever sick. Okay? Well, what I think we need to do then is apply our definition in a systematic way. Should we think that grief is a harmful dysfunction? Well, one of the things that one learns when you study grief and bereavement is that it does have a quite remarkable range of physiological effects on our bodies, many of which are adverse. So it's been observed that in the course of grieving, many people report or exhibit cognitive difficulties. They have difficulty remembering things. They, seem to misplace their car keys or their wallets or whatever. Sometimes their reasoning processes seem to be slower than they otherwise would be. There are effects on the cardiopulmonary system. In the throes of particularly strong grief episodes, people will have increased heart rate or shortness of breath. Disrupted sleep, insomnia, inability to sleep, or disrupted sleep is not uncommon, as are negative effects on digestion. And I think in general, right, what we see in many bereaved people is what we could probably call a kind of stress reaction. And in the worst cases, I suppose, it has been noted that sometimes grieving seems to be a precursor to death. So no doubt you may have heard, and this isn't entirely mythic, occasionally individuals will suffer the death of someone particularly close to them, say a spouse, and not too long after that death, the bereaved individual undergoes a period of decline in health that seems to kind of culminate in their dying, right, earlier than they might otherwise have. So it seems clear that we can think that grief is at least associated, right, with a number of conditions of our bodies, a number of physiological conditions that are certainly not good for us in a certain way. But I would want to contest that these represent dysfunctions. Okay? So why think that these various physiological changes that are associated with grief aren't themselves dysfunctions? Well, I think in order to understand this, we have to make reference to a problem in the philosophy of medicine known as the reference class problem. Okay? So if you weren't paying attention now, this is probably the moment to pay attention because things will get ever so slightly a little bit trickier. Okay? When we talk about dysfunction, we can only really define a dysfunction relative to what's sometimes called a reference class, right? We have to say, right, of some condition that it's a dysfunction with respect to or in comparison to some class of individuals that we're thinking of. Okay? I think the clearest way to appreciate this is with respect to conditions at, if you will, the beginning and the ends of life. Right? Those are sort of the cases where I think the notion of a reference class is most perspicuous. Okay? So suppose that you are a developmental psychologist or an educational psychologist, and you have before you two young people, one of whom is 5 years old and is struggling to learn how to read, and the other of whom is 12 years old and is struggling to learn how to read. Well, the 5-year-old is probably not developmentally disabled, given the reference class that would seem to fix his or her situation. Right? It's not all that uncommon for people early elementary school age, 5-year-olds, to take a little while to master the basics of reading. Right? And so, right, if you were a psychologist looking at a 5-year-old, you would probably say to yourself, well, this is something to keep an eye on, right? We want to make sure that this person eventually is able to read and able to function well enough in the world. But as yet, we don't have reason to think that this person is suffering from a developmental disorder. But the answer, of course, might be a bit different with respect to that 12-year-old patient. Right? By that moment in a person's development, they typically will, right, develop the ability to read in their native language. And, right, in light of that, if you were an educational psychologist, a developmental psychologist, your reference class for that individual would be, sort of early adolescence or something like that. And then what you might say is, yes, there is something dysfunctional going on here, or at least we have reason to think that there is. We can also see that same point illustrated about that point about reference classes illustrated when we think about conditions associated with aging, right, with the later stages of human life. So suppose that you're a physician and you're considering two patients, one of whom is 35 years old and has sort of mild chronic joint pain, and the other of whom is 75 years old and has mild chronic joint pain. Okay? Should you think that one or the other or both of these individuals has, say, arthritis? Okay? Well, given the reference class for the 35-year-old, this would seem to be a more troubling presentation, right? Typically, 35-year-olds don't, right, have these kinds of difficulties with the flexibility of their joints and inflammation of their joints and so forth. It's not unheard of course. But, you know, as a physician, you'd probably look at that and that would raise an eyebrow, right? You'd be wondering, you know, is there something going on with this person that needs further investigation, further interrogation? If the patient, on the other hand, is 75 years old, then it seems to me that the physician would rightly look at that patient in a different light. Most all of us, right, will have reduced joint flexibility, greater tendency toward inflammation, greater tendency toward pain in the joints as we age. And so it may not be the case, right, that 75-year-old should be diagnosed with arthritis exactly, perhaps, perhaps not. But the relevant reference class is going to be, well, not 35-year-olds, but 75-year-olds. So what this point about reference classes, I think, underscores is that when we think about what it is for a condition to be dysfunctional, and hence what it is for something to count as an illness or a disease, we can't simply think about the individual in front of us. We have to also think about what reference class it is that we're using to make sense of who they are, right? What sorts of things we should expect out of individuals with this sort of physiology or at this life stage or have undergone certain kinds of experiences and so forth, okay? And this is a pervasive problem, right, within the philosophy of medicine, right? Everywhere you go in the philosophy of medicine literature, people talk about this reference class problem, okay? Now, I want to turn in a moment to back to our discussion of grief, our ostensible subject. But before we do that, I think that what we just learned about reference classes shows us that we need to alter ever so slightly that definition of disease or illness that I gave a moment ago. So remember that we began by saying that a condition of someone's being ill is that the phenomenon in question is a dysfunction of their bodies. But I think we should actually say that it's a dysfunction of their bodies as measured against the relevant reference class, right? That seems to be the more exact, more precise way to cash out what it is that we are driving at when we think about some condition being dysfunctional. So what might that say about grief, right? Should we think that grief is dysfunctional, right? Again, with reference to what seems like the appropriate reference class. Okay. Well, what's the relevant reference class for thinking about grief, right? If you were a clinician, a psychologist, say, or someone involved in end-of-life care, perhaps, what group of people would you think of as the individuals with reference to which we should evaluate, right, whether grieving is dysfunctional? Well, of course, if we look at all human subjects, then the answer seems to be that grief does seem dysfunctional, right? If I had, an auditorium packed with individuals and, I picked one at random and they told me, well, I've had shortness of breath and insomnia and some anxiety and, heart palpitations and, upset stomach and all these other sorts of things, I would say, wow, are you okay? Right? There seems to be something going on there, right? Something medically or clinically significant. But at the same time, that doesn't seem to me to be the right reference class in the case of grief, right? The right reference class in the case of grief seems to instead be those human subjects that have undergone the loss of someone who matters to them. To give you sort of an analogy here to drive that idea home, consider the condition we now call post-traumatic stress disorder. Okay. Well, this is a diagnosis that requires putting the patient's history into context, right? One wouldn't think that post-traumatic stress disorder should be ascribed to someone who hasn't undergone anything traumatic, right? It's sort of a condition, right, of their having this illness that they've undergone a traumatic event or been a witness to a traumatic event. So it doesn't seem in the case of post-traumatic stress that the right reference class is all of humanity, but rather people who've undergone traumatic events. So too, I would suggest in the case of grief, right? Sure, grief looks like a dysfunction if we compare a grieving person to just anybody picked at random. But I don't think we should be comparing them to anybody who picked at random, any more than we should compare the person who has PTSD to anybody picked at random. We should be comparing them to individuals who've undergone trauma. So too, I think we should be comparing the individual with grief to other individuals who have undergone whatever seems to be the pertinent experience in this case, namely the loss of someone who was close to them. Okay? And I think when we look at it in that light, then it seems to me to be less plausible to think that there's anything dysfunctional going on here. Okay? This is to say that people's histories make a difference, right, to how we conceptualize whether they are sick or not. Okay? So I take that to be a fairly good argument, I hope it's a good argument, for the thought that grieving doesn't typically or usually satisfy that first condition of the hybrid model, right? It's not dysfunction with reference to the reference class that seems to be the right one here. Now, you remember the other, you'll remember the other part of the definition is that the dysfunction has to be harmful, has to be bad for the person who has it. Okay? Now, what should we say about this condition in connection with grief? Well, it's certainly true that grief nearly always feels bad, right? The emotions that are most strongly associated, right, found in grieving are things like sorrow and sadness. That's, I guess, the paradigmatic one. But of course, people also undergo other emotions in the course of grief episodes, many of which are not fun emotions to have either. They will undergo guilt, anxiety, worry, disorientation, any number of other emotions that are typically emotions that we don't tend to welcome. So grief nearly always feels bad. Is that sufficient ground for saying then that grief is harmful to us? Well, one thing to notice here is that the relationship between something's feeling bad and its being bad for us is a bit trickier than we tend to recognize. Okay? So there are some unfortunate individuals who are born, it's a congenital condition, with what's known as congenital insensitivity to pain. Right? They have an inability to feel physical pain. Okay? Now, at one level, that might sound like a good thing. None of us are big fans of pain. But on the other hand, they've also been deprived of their body's alert system for threats to their tissues, threats to their bodies. Right? They're not going to undergo, right, the painful experiences, right, that you and I undergo when, say, we stub our toes or we break an arm or something like that. And of course, that pain has a point, right? That pain is a way of alerting us, right, to the fact that there is something dysfunctional going on in our bodies. So congenital insensitivity to pain, although you have the benefit of not undergoing pain, it doesn't seem to me is a good condition to be in. Right? We wouldn't want to be insensate to pain. It wouldn't be good for us. Likewise, think about something like fever. Right? Fever, it seems to me, is arguably, in many ways, a good sort of discomfort or pain. We need it. Right? It alerts us to the fact that our body is fighting off some infectious agent or some foreign agent. Right? Again, it doesn't feel good to have a fever, and at its limit, of course, it can itself be a dangerous condition. But at the same time, we wouldn't think that it'd be a good thing for us to be deprived of fever altogether, right? It's an important indicator of something going on to our bodies. Now, I would argue that grieving is probably very much like these particular kinds of phenomena as well. Grieving is our psyche's way of telling us that something very important has happened, right? It's our psyche's way of telling us, somebody that matters a lot to you is no longer present, is now absent. And I would suggest that grief, right, seems to play the same sort of role psychically, or a similar sort of role psychically, as physical pain or fever does with respect to physiological illness. Right? It's there, in some sense, to draw our attention, right, to something that we should attend to. Now, before saying a little bit more about the application of these remarks to grieving, we earlier needed to revise our hybrid model to deal with the reference class problem, but now I think we need to revise it in a second way. What I think we should be saying when we talk about harm is not whether the condition of the person is harmful just as it is, but whether it's harmful all things considered, right? Taking into account perhaps the benefits, right, that the person enjoys as a result of the condition in question. Okay? So notice that we've moved there from saying, is this a harmful condition taken as such or just taken as is, to taking into account all of its effects on us, is it a harmful condition to have? Well, I think there's good evidence from psychology that there are a number of psychological benefits that accrue to us because we grieve. One way I think to understand some of these benefits is to make reference to what's sometimes called the dual process model of grief. It's a model that I find fairly attractive. What the dual process model basically says to us is something like this. Grief is an event, right, or an episode where we oscillate between two kinds of orientations or two kinds of outlooks. On the one hand, one thing that goes on in grieving is that we are trying to address or understand the loss that is represented to us, or represented for us, by the death of someone who matters to us. So this is the material that is over here on the gray part of this particular diagram, where what's going on in this part of grieving is people often sort of experience, intrusive thoughts of this person whose death prompts their grief. They're trying to sort of process, right, the sort of sadness and kind of sense of their world as having been diminished or damaged in some way. But at the same time, or again, it's kind of oscillating process, people are also, in the course of grieving, trying to build toward a future in which that individual is no longer present, or at least not present in quite the same way. Right? There's a way in which what we're doing when we're grieving, according to the dual process model, is also altering our lives, right, to take into account that this person is no longer present in our lives. So this will involve undertaking perhaps new activities, establishing new relationships, taking on new aspects of one's identity. And what the dual process model, in effect, says to us is that we kind of do both of these things at different moments in the course of grieving. But as time goes on, the backward-looking part, the part that's oriented toward the loss, kind of recedes, right? And the forward-looking part becomes more prominent. Okay? Now, this, it seems to me, is one picture, a fairly attractive picture, of the ways in which grief seems to be beneficial to us. It allows us to grasp, right, fully, something that we have lost, right? To understand fully the significance of the individual who has died, but also to figure out a way in the world, right? To figure out how to live in the world in the light of their death. Okay. Now, in my own book, depicted in the slide here, I argue that there are other ways in which I think grief is valuable to us too. I think that grief contributes to our ability to understand ourselves. So when we are grieving, what is going on is that a relationship in which we had invested ourselves has to change or has to alter. We cannot relate to a person who is dead in the same way that we can relate to someone who is alive. And what this tends to do is it tends to lead us to question, right, exactly why that person mattered to us, try to understand better why they mattered to us, and then to figure out, again, what our lives are going to look like going forward. And the upshot of this, I think, is a kind of enhanced self-knowledge or self-understanding. Okay? Likewise, I think grief has the potential to strengthen our ties to other people. We may well be grieving someone whose death is also significant to someone else. They too may be grieving. And this is a way to enrich or enhance our relationships to them. But the overall picture here that I would like to advocate for is that we should think of grief as a tool for dealing with loss. Right? And it would be unfortunate, I think, if we thought that grief's sufferings, which of course are not insignificant or trivial, if we thought that those sufferings sort of had no wider aim, no wider purpose, no wider value for us. I think they do have a wider aim or purpose or value for us. Okay? And the significance of that, then, is that this seems to me to be good evidence in favor of the thought that when we look at grief in its totality, not just sort of thinking about, again, the pains associated with grief, the psychological pains or the physiological changes that seem to be unwelcome, when we think about it in its totality, thinking about both the ways in which it's detrimental to us, but also the ways in which it's beneficial, then it seems to me plausible, right? That, in fact, what we're dealing with is a condition that isn't typically bad for us. Okay? Now, if we bring these strands of reasoning together, what do we have then? Well, I hope to have given some good reasons to think that, on the one hand, grief is not a dysfunction for most individuals when we think about the relevant reference class, again, that being those who've suffered a significant loss. And in most cases, it's not going to be on balance harmful to us. Which doesn't, of course, mean that there aren't some harms associated with it or some parts of it that are perhaps very harrowing. But at the same time, we will, I think, typically find it to be a beneficial thing to grieve, and to grieve in a way that is robust and meaningful. Now, what this means then is I'm not sure that either condition, right, of the revised hybrid model of disease that I put forward is satisfied with respect to grief. What that seems to suggest then is that we should be very hesitant to think of grief as a disease, and in turn we should be hesitant to use this language of a grief pandemic to the extent that that language seems to imply, right, that grief is a disease. Okay. Now I want to raise here a final set of worries about medicalizing grief. There's an assumption, I think, that's tacit, right, in discussions of medicalization that may strike you as kind of obvious, but is important nevertheless to bring to the surface. The assumption is something like this, that if something is an illness, right, if it is a disease, then we should be treating it with medical interventions and techniques. Okay. That doesn't seem to be obviously the case in every instance. For one thing, we may not have available to us good treatments, right, for the condition in question. Right? We should be hesitant to treat something that is an illness if, in fact, we don't have good reason to think that the available treatments are good treatments. And one of the things I think that I would invite you to think about is what you would suppose would be a good treatment for grief were, in fact, an illness. Those who've advocated for the medicalization of grief are often enthusiasts for the use of antidepressant drugs, anti-anxiety drugs. The more important point for our purposes, though, is the second bullet point here. That sometimes medical treatment is itself harmful, right, or has untoward, what we might call side effects. So let me outline what I think some of these harmful side effects could be of medicalizing grief. So the first side effect has to do with a notion that was identified by the philosopher of science Ian Hacking in the 1970s. Hacking made what I think is in retrospect kind of looks like an obvious observation, but once you think about it, it's actually pretty profound. So think about what it is to classify, let's say, a pathogen as a pathogen responsible for an illness, right? So when we figured out that the HIV virus was responsible for AIDS, okay, we, said, okay, this pathogen is the one that is responsible for people developing AIDS. That doesn't change the pathogen. Right? The pathogen doesn't care, right? The pathogen doesn't, sort of have a light bulb moment saying, oh, I'm responsible for causing this illness, right? There's not a conscious being, right? Nothing is altered about the pathogen, right, by our discovering this. Diagnosing human beings is different, right? We are conscious beings, right? And when we are told that we are diagnosed with a certain illness, typically that changes in various ways our relationship to that condition. So think back, right, to one of the examples I gave near the beginning of the talk of a condition that has become medicalized, namely alcoholism, right? Imagine the change in your mindset in being told, say, if you were a patient being treated for alcoholism in the 1950s, imagine the change in your mindset from being told, well, you're not a bad human being, you have a genetically based addiction. Right? Notice that invites us, I think, to relate to our condition in a different sort of way, or would invite the alcoholic to relate to his or her condition in a different sort of way, right? Not as a kind of moral failing, but again, as something that has arisen from physiological facts about themselves, okay? And so what Hacking means when he uses this phrase, looping effects, right, is that when we use what he calls humankind's, right, terms like alcoholic and so forth, we are, in a way, right, leading or encouraging individuals to think about themselves in certain sort of light. Right? To think of oneself as ill, I think, is different than to think of oneself as, say, lacking in moral character. Okay? So he's making, I think, the fairly obvious point that medical diagnoses affect our self-conceptions. Right? They affect how we understand who we are, right? And they affect how we relate to the conditions for which we are seeking help. Now, I don't know quite what the effect would be. I mean, I admit that this will have to be somewhat speculative. I don't know quite what the effect would be if it were common for people to be diagnosed with grief disease, whatever we want to call it. Okay? But I don't know that the effects would be entirely good. We might come to identify with our grief in a way that I don't think is entirely healthy. That is to say that, all of us will, through the course of our lifetimes, grieve, but I'm not sure it's a good thing for us to think of ourselves as grieving individuals, or as grief sick, or as stricken with grief, or some such thing. I worry that this might stymie people's ability to be resilient and to recover from grief, right? To think of themselves as prone, right, to a kind of illness as opposed to simply undergoing a stage of human life. So admittedly, this is speculative, but I think it's an important set of issues to grapple with, right? How would thinking of ourselves as sick with grief, as opposed to merely grieving, alter our understanding of ourselves and our relationship to this condition? I have to say that myself, I worry that the effects would not be salutary. Now, another thing that proponents of the medicalization of grief say, well, you know, being pragmatic here, medicalization will encourage bereaved people to seek out help, right, when their grief is particularly hard to manage. And here I'd offer two replies. First, that this seems to assume that the right sort of help in the case of grief that is difficult to manage is medical in nature. I'm not sure that all grief problems are really medical in nature. It seems to me that one might find a great deal of help when one's grief is troubling from individuals whose credentials aren't medical. Their credentials might simply be that they are your friend, or that they are your priest, or that they are somebody who's gone through grief recently, or, I don't know, crazily enough, maybe they're a philosopher of grief. I don't know. But the assumption here that, you know, the help that one needs is medical in nature needs some defense. But more than this, it's still the case, right, that medical illness tends to be stigmatized in many societies. Many cultures do not look very kindly, right, on individuals with diagnosed medical illness, and in fact invite those individuals not to look very kindly upon themselves. So while it may be true that some people, upon learning that their grief may be an illness, would be encouraged to seek help, it seems to me equally likely that some people would be discouraged from seeking help. I think this may be particularly true with respect to certain kinds of facts about help seeking and gender. So we know from a fairly wide literature about mental health and help seeking that men, right, generally speaking, are more reluctant, right, to seek mental health assistance than women are. My guess is that were grief medicalized, this might have a particularly detrimental effect on the willingness of men to seek out help. After all, this is to invite men to see their condition as, well, frankly, a kind of malady, which I imagine some men, based on their self-conceptions at least, probably would not want to perceive themselves in this way, or have other people perceive them in this way. So I don't think that this is an argument that holds much water in my eyes. It may be true that some would be encouraged to seek help, but I think on balance, the effects would be perhaps negative. Now, it's really important that you appreciate what it is that I'm saying and what I'm not saying, okay? I've given you some reasons, I hope, to think that we shouldn't medicalize grief, and in the end, we should not be speaking here of a grief pandemic. That's to invite a misunderstanding. But it is true that even on my view, grief should be thought of as a clinically significant fact about people, okay? What do I mean when I say this? Well, of course, grief will sometimes be the basis for or a cause of clinically significant conditions that should be treated. There are grieving people who will develop depression, anxiety, that's clinically significant. But notice that what we're saying there is not that they're sick with grief, or rather saying that they're sick due to grief, at least sometimes. Okay? That's a subtle difference, but an important one, right? After all, it seems to me to matter quite a lot how we speak and think about our own condition and how medical professionals, medical officials speak to us and represent to us our condition. Okay? So just as prolonged unemployment can cause depression, right? It seems quite reasonable to think that in that case, a person should be eligible for and should perhaps seek out medical help. But we shouldn't think of them as having unemployment-related depression or some such thing. They simply are depressed. Right? Likewise, in the case of grief, I have no unwillingness to acknowledge that grief can be a source, right, of other clinically significant conditions, but I think we should hesitate to think that grief is the illness in question. Okay? Now, with that kind of brings my arguments against the medicalization of grief to their conclusion. That said, I will admit that I seem to be fighting a losing battle. Recently, in the United States, the primary group of psychiatrists have decided that they will be inserting into their next published versions of the Diagnostic and Statistical Manual of Mental Disorders, something they're calling prolonged grief disorder. You can go find out for yourself exactly what prolonged grief disorder would consist in. But I don't think these arguments that I'm making are futile nevertheless. And it does seem to me that just as we might medicalize grief, that is to say, come to treat it as a mental illness, it seems equally possible that we could at some day demedicalize it because you're convinced by people like me that it's a bad idea. Okay. Now, I want to end by saying a little bit about something that I find additional consideration I think is important here in thinking about the pandemic from a kind of political perspective. So I've been making a kind of ethical and medical case against medicalizing grief, right? I've suggested that talk of a grief pandemic is misleading and probably should be something that we should resist. But I also think that talk of a grief pandemic carries some political significance too. In what sense do I think that this is politically significant? Well, I think when we're invited to think of grief, this mass grief event that we are facing now as a grief pandemic, we're invited to think of this as a set of disconnected individual pathologies, right? So for each individual, again, who has died due to COVID, experts say that there are 9 individuals who are grieving as a consequence. And I think to think of this as a pandemic is to think that there is a set of disconnected, right, individual pathologies, perhaps 9 individuals, each of whom, for whatever reason, managed to be grieving in ways that may not be good for them. But I think that we should instead think that what people are doing in the pandemic when they're grieving is exhibiting a non-pathological response to various sorts of collective failures. That is to say, I worry that thinking in terms of grief, a grief pandemic, perhaps lets us and our leaders off the hook. That is to say, it invites us to overlook that what we're really dealing with is widespread moral injury as opposed to a set of disconnected individual pathologies. So to put it a kind of different way, I think when we think of this mass grief event as a grief pandemic, we're invited to think that the problem is not out there in the world, namely that a whole bunch of people whose deaths were probably preventable died anyway, but that the problem is, so to speak, in here. And this is, I think, a tendency that many skeptics about medicalization have noted, that medicalization results in sick people, and as a result tends to neglect the prospect that these are healthy people living in a sick world. And in my own estimation, I think those who are grieving in response to the pandemic, even if their grief is very distressing and difficult for them, are exhibiting what I would say is a healthy response to a rather sick episode in the world.